Welcome to the channel. Who do we have here? Dr. Nyamute Lynn. So she's a psychiatrist. The reason why we are doing this specific episode this month is because May is
May Mental Health Awareness Month. And this month we're promoting positive mental health because we all have mental health. Whether your mental health is good or it's bad, we all have mental health. So yes, it's me.
So I have a few questions lined up for her, which she will try her level best to answer. By that disclaimer, we mean that the answers might not be necessarily adequate, but we are working with her to her level best. So let's take this away. You are a psychiatrist. How long have you been practicing?
This is my second year as a psychiatrist. In the mental health space, I've been working in Madari as residents, and for 3 years before that.
So it took 3 years before you qualified?
Yes.
In that regard, psychiatry is really something to envy in terms of MEd. Isn't it the shortest course that MEd wise? Is there one that's shorter than psychiatry? Which
pediatrics, IMEd, they're all 3 years. Pediatrics, IMEd, anesthesia is 4.
Anesthesia is 4.
So the medicine courses, because pediatrics, IMEd, and psychiatry are in medicine.
Oh.
Yeah.
Okay.
The medical courses.
Okay, and as opposed to the
surgical,
which are like
a million years
or twice the duration that you guys go through.
No, a million years. I guess there's Zinja Tropa.
So?
Apologies.
So we have not taken any offense as surgeons. The other way of looking at it is that if you guys are taking 3 years and us guys are taking around 5 to 6 years, so we are at the bare minimum twice as good.
Not really.
As a psychiatrist, you tend to see patients. There's this book that I read, that I'm reading. Mm-hmm. I don't think I'll ever finish reading it. Also Human. Have you heard about it? It talks about doctors' lives, and then there's a chapter that touches on reasons why people choose the paths they choose as doctors.
Okay.
So let's say as a physician, probably you had a family member who had a medical ailment, probably someone was diabetic, hypertensive, you went through the rigors of management as a relative, and you felt like you want to go into that field because you want to manage that. Or you also have a medical condition and you go into it because you want to manage that. So if we were to extrapolate, psychiatrists would also probably go into that field because they have relatives who've suffered such ailments, or because they themselves probably have caused psychiatric issues. So my question is, do psychiatrists need psychiatrists too?
Yes, of course. And that's true. There are people who, people choose their career paths for a reason. Some it's direct, and we've had a few colleagues who would come to you and tell you, I'm going through this and this, and it's really a down moment for me, or I'm having this and this issues. Psychiatrists, yes, or rather when you're in training in the program. But even other residents, I had enough friends from even surgery, obs-gyn, would come and ask, psychiatry related things. I'm getting anxiety when I go to theater and all that. But not that aside. So yes, we are part of the general population. We're just a select of the general population. And when we say like schizophrenia, for example, affects 1% of the general population.
And it would also affect 1% of the psychiatrists, if not more. Oh, okay.
It will affect. Yes, so at the end of the day, we're just a sample of the general population. And yes, the same way the general public needs psychiatrists, we also need psychiatrists. And I think another thing why we need psychiatrists as well is because, but there are days actually, like I have my go-to friends, because there are days you sit in, you see clients, things get heavy.
A lot to take on.
Heavy, until you're wondering, okay. So yes, psychiatrists do need psychiatrists to also help you
process and come out of it.
Yes, and also like the that's one. But yeah, so also for yourself also to just be in a clear mental space. Yeah.
I think, but all that you've described, so you've said some days you go through a clinic and you see patients and they offload stuff on you and you feel like you need to decompress, you need someone to talk to.
Yeah, that was the word.
I have all the words. You need someone to talk to. So, implicitly, you don't necessarily need a whole lot of care in terms of your mental health. You just need someone to talk to. So, in terms of mental health care practitioners, is there a tiered approach to it? So, basically what I want to ask is there a difference between a psychiatrist and a psychologist? And
Yes, that's a very common question even our clients
apart
ask.
from spelling and pronunciation.
Okay, so and it's also a very common question that our clients ask. Is there a difference between psychiatrist and psychologist, and where do I go first, and how does one help me that the other one will not help me? Anyway, yeah, so psychologists do more of talk therapy. Psychiatrists do more of seeing how the medications work to improve your symptoms. So, yeah, psychiatrists are medical doctors. Psychologists do more talk therapy. And do we need, we need someone to talk to. We all are, in as much as we prescribe medications more, when a patient comes and tells you that they're going through a certain thing in their life, you not tell them, I'll not tell you anything, go to the psychologist and take the meds and go to the psychologist. You still have to get into a space where you can still offer that, what we call supportive therapy. So supportive therapy is more just like, you're going through this space, what kind of maybe help do you need? So it just helps you probably to understand the problem you're going through at that point, and what solutions do you have within your reach to try and solve that problem. Kushindana tunakotuma cool like a psychologist.
Sasa hiyo ndo tena the next question that I have. So I'm a patient, sindio? Not me. I'm representing the patient population, sindio? And I'm there next to you, sindio? And then I'm in my acute phase where maybe I need medication, so psychiatrist has come through, sindio? But as an addendum to the medication, I'll also need talk therapy, which I am hoping you'd use the right word for, like psychoanalysis, those things that you fling around in terms of the knowledge base you have. So I need that therapy. You've already given me medication. Does it behoove me, or according to your principles, will you also be the one to walk that journey of that therapy with me, or will you be, like, do you have time to have proper talk therapy with me, or do you have to send me to a psychologist?
So, okay. So the psychiatrist, psychologists, there are people who've trained in both clinical psychology plus psychiatry. But I think as a basic, we do the psychoanalytic therapies during the training. So it's something that you should also know how to do. However,
in practice?
Yes, in practice. However, it's not, stick on your lane. There are people who that is now their job, that is their full profession. So, but you still know how to carry out. Like, for example, if I tell you need CBT, I know how CBT is done. I can do CBT. But for someone who's been trained particularly to do that.
What's CBT?
Cognitive behavioral therapy.
Okay.
Which is basically a type of talk therapy that helps you change your behavior and your thinking.
Okay.
Yes. So
you'd start off the medication, stabilize the person, and then forward them to the
psychologist. Yeah.
So where are we?
Yeah, seated right here.
If you notice that the light has gotten a bit darker, this guest of ours has gone and had a conversation for 45 minutes. So slightly less than 45 minutes, but still atrocious. But that's okay.
We said psychiatrists need therapists too.
Yeah, she went and had a talk session and giggling session. But that's good. That's good. So you've seen a patient, you've therapized them. Is that a word? You've talked to them, and then you meet them out there. in whatever other setting, now they're functional. Of course, you recognize them. Do you go say hi to them? People know you're a psychiatrist. So I feel like if you go say hi to them, people might know they've seen you probably in a professional capacity. So does that prove like a difficult moment?
Not at all, because we have other friends who are not patients.
Okay.
So me just saying hi doesn't necessarily mean that I've met you in a psychiatric setting. I could have still met you in a psychiatric setting, maybe brought in a relative, for example, maybe brought in a good Samaritan. So I feel like thinking so tends to propagate stigma a bit more.
You're preempting my next question.
And it's very easy. Like if you go for a cocktail party, you say, meet Dr. Tabu. He is my surgeon. But no one will ever say.
That sounds nice.
But no one will ever say, meet Dr. Nyamute. She's my psychiatrist. No, there are actually a few people who say that. Yeah, they're upfront about it. They do. And I feel, and we're encouraging this. The more people own their stories and talk about it, the more it's easier for them not to go through stigma, and particularly perceived stigma. Because you're like, I went, not me, but there are people, for example, I went through depression. I've talked about my story on whatever platform it is that I've talked about. I have told people maybe these are the steps I took. This is what I really went through, and there were ups, there were these downs. Maybe I took medication, maybe I went for therapy, and this is how. So when I meet my psychiatrist, I'll not be scared to say, this is Tabu, Dr. Tabu, my psychiatrist, But the fact that there is stigma, not even be us who'll be, it will be the patient who will see like, like they look at you and then they see, and then they turn off eye contact very fast. But personally, me, if I meet you, I'll say hi. Hi, how you doing? How have you been?
So if you see a patient being coy about being your patient, you necessarily wouldn't push up yourself against her. No. She has to be receptive.
Yes.
Okay.
And you can always tell. I think one of the things, and you pair in psychiatry, mental health, or mental health professionals, we pick up nonverbal cues very fast. So they don't have to say that they don't say I was your patient, but you can already tell from their body language, from their nonverbal expressions that this is someone who doesn't want to talk to you or even have that conversation started or initiated or even prompted or even suggested.
You said that you can pick up nonverbal cues. What have I just said? Nonverbally.
That you're shady.
I feel like even as a doctor, because I've been practicing as a GP, sometimes I have stigma against mental health issues. Not because I abhor them or I judge people, but because sometimes it's difficult to manage mental health cases. Because they're quite nebulous. If someone comes with a headache, someone comes with a bleeding, whatever, or diarrhea, so to speak, you know what you're managing. But mental health issues sometimes seem so cloudy.
Yeah, that's why we are very smart. Thank you.
Oh, yeah, they're really smart. I appreciate whatever they're doing, whatever stuff they're covering. I wouldn't want to delve into it. And that's why most medical practitioners don't know about psychiatric issues. And when they get a patient, they panic. Refer. And it feels like they have stigma against it. But so I think knowledge is one very great step to take if you want to do away with stigma, even for the relatives. If you just read around the conditions, you'll see that these are things that have been there, these are things that can be managed, these are things that have as any other illness, they can be chronic, there are acute phases. And
can I just jump in?
Please do. I was struggling.
You brought out something very important, and you'll find how ignorant a lot of people are, even the educated, extremely ignorant. And there's a lot of mental health. Now the stigma creates a space where follow-up becomes an issue. Like we have patients who you give them, or rather you tell them, this is your diagnosis. For example, maybe they have schizophrenia or bipolar. Yes, and also in the mental health space, I think there are disorders that are stigmatized more than others. So when they come, yes, and then you tell them your patient maybe has schizophrenia or maybe has bipolar, those ones are usually very stigmatized upon. You'll find they're really trying to push you, or rather push the notion that they have an anxiety disorder, because that's a bit more acceptable.
Panic attacks have been there and people have them.
Yes. I'm just having anxiety. Nika anxiety too, ka depression too, but the minute you say, no, you're not having your anger outbursts, for example, or your excessive talkativeness, those are not symptoms of anxiety. They're more of symptoms of, or rather, whatever picture we have in this space right now is in keeping more with bipolar. They'll be like, no, it's anxiety. And they'll insist on anxiety. And when they move to the next doctor, once
they've fallen
yes,
out
like
with you.
Yes, because they're like, you have refused to buy their narrative. You insisted it's bipolar. You want to give bipolar medication, and they don't have bipolar. They move to the next doctor. They go and say I was being treated for anxiety. So now it creates a space where I find taboo refer this patient for anxiety. Like, but this patient has clear symptoms of bipolar, and we are wondering what is going on. I call Tabu, and Tabu tells me, no, that patient actually has symptoms of 1, 2, 3, 4, 5. I've been following them up, and I think that space of just this medical hopping from space to space, trying to find a particular diagnosis, trying to force a diagnosis because it sounds better, it just creates more and more stigma, and it prevents, or rather it interferes with the recovery journey in general. That's why I find people getting a lot of relapses, because you're not getting the medication, you're not taking the medication, or rather following up the whole management plan as it was, because you're not comfortable with the diagnosis you are given. And I think the name is just a name to just help know how to manage you. It doesn't define who you are, So whether it's bipolar, whether it's anxiety, it's a name to just help know how to manage. Manage.
Know which algorithm to pick up.
Yes.
Because if you don't define it, you can actually pick up the the real algorithm when you're managing someone for bipolar.
Yes.
Okay, touche. That's quite smart. How does insurance work with mental health? Has it embraced mental health? Or does it treat it as see how insurance doesn't cover medication, like supplement medication? Do all insurances cover mental health as much as they cover other medical ailments?
Not as much, and I think, but one thing is we've come very far. Like our policymakers have really done so much in trying to push that narrative forward. So far we have so many insurances that are doing, or rather covering for mental health, but yes, there's a cap. They put this is the limit we will pay if it's a mental health diagnosis, compared to if it's anything else. If you're going for surgery, for example, or if you're being admitted maybe for malaria or pneumonia, they'll not cap it. But for mental health, a lot of insurances are putting caps. There are some which are very friendly, which are not. But that's also something we're still pushing, like the advocacy and
fine-tuning the policy. You guys are still at it.
Yes, we are still at it.
You need to keep at it.
We're still at it. Yeah. Yes, but one thing for sure is they don't. Most. There are few that do, but most will not cover for addiction and suicidal attempts, because they feel like they are intentional.
Okay.
That is their defense. Yes, that it's an intention. It's a behavioral thing that.
It's your mind that has driven you to do it. Even they don't think that mind is sick.
Yes. So rather than looking at it like, by the time someone is suicidal,
disappointed in them, baby.
By the time someone is suicidal, they've probably gone through a lot of depression, and depression in itself they will cover, but you're
Now
so
once
severely depressed
the point
that
of-
you're suicidal. No. You are
Umeamua sasa.
suicidal. Wewe ni wewe umeamua. They don't look at it like it's an illness. They look at it like it's a behavior you chose yourself. So suicidal attempts and drug addiction, I think we're still struggling quite a bit with.
Are there like mental health issues which are not severe enough that you need to speak up about it? Basically, is keeping a lid on some of the issues, a good coping mechanism? And I've said some of the issues, not all of the issues. Are there some issues that when you don't talk about it, then you don't make them real? Basically, you just tulia and they go away and you are good and you continue and no one is suffering.
Swali yako iishi. So you brought us a good point, and I mean, as we started, May is mental health awareness. We were talking about promoting positive mental health. And I started by saying that everyone has mental health, good or bad.
Good or yes.
And that's because regardless of what you do, there'll be something that will affect your mental health during the day in one way or another. We are the ones who decide now what next. So different people have different coping mechanisms. One of them, for some people, it's healthy coping mechanisms. For some people, it's poor coping mechanisms. So learning what works for you. So being, first of all, self-aware. What works for you? And I think one way with that is seeing from reflecting back what worked
for you before.
What didn't work, so you know not to go back there.
So what didn't work would be something that threw you into the doldrums.
Yes, and made things much worse.
Okay.
And what worked, even if a little, whether in a magnified way or very small way, if it worked, then it's something you probably need to build upon. If it's something that didn't work, you need to know this is a coping mechanism that I need to be avoiding. With that same, for some people, as you said, focusing on a problem sometimes may magnify it. And we said on
vindicated.
and we said earlier, CBT, cognitive behavioral therapy. Part of the cognitive is just like to do with your thinking and all that. Part of the things that we talk about is something called cognitive distortions. And one of the cognitive distortions you can have is what we call magnification or minimization. So magnification is basically when you have a small problem,
you amplify it.
Thank you. So I wouldn't want to use this word, but I'll use it. You sort of make a mountain out of a molehill. Minimization is the opposite. So you're trying to deny that you have problems.
Sweep it under the rug.
Yeah. It happened. It's not affecting me, and of course, now it eventually comes back to affect you. So now those cognitive distortions. It's now also you can be able to do that by yourself, depending on how self-aware you are. Sometimes you may need help, and that's why we said not everything. Sometimes you may need to talk to people. Some you can talk to yourself. So having self-growth is very, very important. And that is, it will help you now be your own support system sometimes, such that, I mean, there's things which you can be like, okay, we've been through this before and this is what we did. It worked, or this didn't work, so this is what we're going to do. And probably didn't need anybody to tell you that or to have that conversation with you. And sometimes you may need to talk to a friend, sometimes you may need to see a professional. Yeah, so different kind of problems.
That question has been very well answered. I'm not saying the other questions have taken a hit intellectually.
Wait.
So
Yes, and many other therapies. People with anxiety, different therapy. People with depression, there are like so many different therapies that they can be used. So it's not one shoe fits all sort of a strategy. Yes, we do a lot of different things.
So no one should be scared of whatever issue, whatever, as long as it's in our effect. Don't be scared of going to see a psychiatrist/psychologist.
Yes.
They have an armamentarium of skills that they are willing and able to discharge on you, so that ultimately you are discharged from the hospital.
Yes.
Umesikia rhyme scheme?
Nebako. And the other thing is, I mean, psychologist, psychiatrist, I don't think it matters where you start.
You'll be routed to the proper channels.
Yes. As long as someone is qualified person in the area they are in, they'll be able to refer you if need be to. If you go to a psychologist and they feel like you're not in the space, you need medication, they'll refer you to a psychiatrist. Come to a psychiatrist.
Qualified is a very good thing. Qualifies the statement quite aptly. Imagine you have to go on issues and they're just talking to friends.
Yes.
That
sometimes that worsens.
It worsens it.
Sometimes. Depends on I mean, everything has its good and its bad side. Yeah, so sometimes that can worsen. Sometimes you actually do need a professional.
Okay, just check. High five.